Hello guys, and welcome to another video. This time we're going to discuss a topic that's near and dear to my heart: long axis versus short axis technique and appropriate needle manipulation technique under ultrasound. As a part of the intern ultrasound course, we did a central line lab, and I felt like I really didn't spend a whole lot of time on this particular subject, the art of driving needles. We did speak a lot about the procedure itself and the requirements for image capture when placing a central line. However, I really wanted to make a passionate argument about long versus short axis and why I think long axis is superior. However, I really would like you guys to master both of these techniques because they may be required in different circumstances, and I know that there's a lot of folks out there that I have a lot of respect for that prefer a short axis technique. So both of the techniques are valid. However, I'll make you some arguments about long versus short. You should really learn both of them, and really there's some evidence to show that short might be easier for novices. However, I think the time investment that you spend in learning long axis technique will really pay dividends in the end. We know that you should be using ultrasound for procedures, so I won't even belabor the point. Multiple professional groups and even the government is now requiring or asking that we use ultrasound for central line placement, particularly in the IJ and femoral regions. And you can even use this technique using when attempting a subclavian approach. So really, it has become ubiquitous, and you really should try to master this ultrasound guided approach. So anytime you have to drive a needle to the target, you're going to want to use ultrasound. Okay. All of these procedures require you to have good ultrasonographic technique. The question you should be asking yourself is, am I doing this right? Or am I just site marking? A lot of times when people tell me I prefer short axis because I find it to be easier and it's what I'm used to, really what they're referring to is not really ultrasound guidance. They're really talking about site marking, like you would mark a site for an abscess or for a paracentesis, where you just go ahead and you find the target of interest on the screen and you just cut into it or put a needle right through it. Okay, most of the time, or a lot of the time, that's appropriate for an abscess, or you don't have any, particularly dangerous structures behind it, or you just want to kind of cut until you get pus and stuff, and you just want to find the most purulent pocket to go after. That's perfectly fine. Okay, I'm not a hater of site marking. Okay, and I do think that ultrasound guidance is superior, and I'll tell you why you should be using it for peripheral IVs and central line placement and really most procedures, nerve blocks and that kind of stuff. Ultrasound guidance really means that you're going to see your needle tip the entire time. Okay, that's really what it means, and I'll show you why these techniques are important. Now, this is a general talk. It's not really supposed to be centered around central venous cannulation, but it kind of is, because really that's one of the most important settings in which you'll be using ultrasound guidance techniques. So we're going to talk about things in the context of CVC placement. However, really understand that these techniques apply to anything you're doing. Also, another good goal is to not place a carotid artery line. So I'll show you some techniques that you can use to avoid that. Okay, several steps to avoid that. So what are the required views that I asked you guys to obtain for CVC placement? One, I would like you to scan both sides. Okay, you don't have to clip both sides, but I do want you to scan both sides, and you'll come to regret it if you don't, because you can select a very, very difficult right IJ and spend a long time trying to stick it and cause a carotid, injury there on that side. When if you had just scanned the left side, you would have seen a perfectly appropriate IJ, a plump IJ for whatever reason. Okay, so you really want to survey scan both sides before you even start the procedure. The next step is going to be obtaining spectral Doppler of vein and artery. Some people find this excessive. They say, well, if you're compressing the vessel and stuff. I really do think that spectral Doppler is an appropriate technique, because it's not going to be equivocal. It's going to really tell you what you need to know, and I'll show you how different techniques can be tricky but spectral Doppler of both vessels, documenting that and obtaining a still of each of the vessels with Doppler on it is really, really, foolproof. You're obviously going to use a traditional approach of compression, and really compression serves two purposes. You're going to compress the vessel all the way to make sure that you can compress the vessel all the way, that you're not dealing with a clot there or anything like that, or a tumor or something else going on. You're also going to show that one of these vessels is compressible. Now just remember, with enough force you can compress the artery, but you don't need that much force to compress the vein. So it's not really showing that you can compress the carotid artery, which you don't want to do, but really you're just showing that the IJ is collapsible. And you're going to want to compress it at a couple of sites and scan down the vessel to make sure that there are no clots or obstructions in your way, or maybe a valve that you're going to hit. And then once you're sterile and you got all your equipment ready, you're going to go ahead and confirm once again the site of the vessel and place your wire. And lastly, but most importantly, you're going to want to scan that wire in 2 axes. I'll show you some examples why, but it's really important for you to scan the wire in both axes before you dilate. Dilation is kind of like the last step before you make a error be permanent. So you really do want to make sure that you're indeed in the vein. If there's any question, just stop. Get somebody to help you. Get your attending to help you. And if you still have doubts and you're not sure, don't do it. No reason to do that. So ask for help. This is a hard stop for you. If you're not sure, you see the wire but you're not sure where it's at, don't proceed. This is just another brief example of why you should be using ultrasound guidance for IJ. Not that I need to belabor the point any longer, but you're going to be wrong about half the time if you use a landmark technique, and you'd be surprised how many people in the community use a landmark technique because that's how they were trained and whatnot. So very important for them to know that really you're wrong half the time. So identifying vessels. True or false, color is an appropriate way to identify artery versus vein. Now, for experienced eyes, sure. However, as a beginner, you can really trick yourself. I've heard of cases where people have misidentified one or the other because of the color. Okay, it's like your brain is almost trained to think that arteries are always going to be red and veins are always going to be blue. And this video demonstrates that you can make any vessel turn blue or red depending on how you position your probe. And you can see a piddling little IJ on the left side of the screen that's really not worth going after. So really be careful with this. Color's not appropriate, use spectral. So the venous waveform. Notice that continuous wave pattern of the venous waveform. It's not going to have the different phases that the arterial flow is going to have, and it's really going to be foolproof. I mean, you put the waveform, the spectral Doppler on the vein, and you're going to get a very different picture than this, the arterial waveform, which is very familiar to you. Triphasic arterial flow. So, long or short, again, both can be done correctly, but the question is, are you doing it right? Ring down artifact. A lot of these needles are designed to really give you a lot of artifact as you're going to use the ultrasound and scan down so that you really can tell the difference between the needle and the surrounding tissue. A lot of them are going to give you this ring down artifact, which you can see at the needle tip. Which is why it's always important to have your bevel up as you're going through the tissue to try and really maximize your visualization of that, and also making sure that you're always seeing the needle tip as you're coming down. So long versus short, again, this is the reason I put these pictures up, this particular picture up, is that really look at how the gentleman is holding the probe. It's really not correct. You really got to stabilize your hand on the patient and make sure that you're getting good stabilization for either approach, okay? But very much more especially for the long axis guidance approach, because you don't want to be slipping on the gel and losing your view and losing the center of your view. So go ahead and make sure that your palm or part of your palm or the three fingers are kind of stabilized on the patient while you pincer grip the probe closer to the base. You don't want to put pressure on this vessel. As you're trying to access it, you want to be almost like floating the probe on top of the vessel, because any pressure you put down is going to help it collapse, and you're going to get a worse view. So let's focus briefly on short axis here, okay? So what am I talking about when I say that sight marking versus guidance? I'm talking about picture A, okay, where the person is really accessing the skin right next to the probe. You're really not giving yourself enough space to really see the needle tip, and you're just targeting the vessel. Very easy to backwall that way. You really want to be starting at picture B, where you're starting off maybe 1.5 centimeters before the probe, before the site you're trying to get to, at a kind of a steeper angle than you would, almost like a 45-degree angle, much steeper than you would for a peripheral IV. And you want to go ahead and get underneath the skin, and then shortly after that identify your needle tip, and making sure. How do you identify a needle tip in short axis? You scan down until the needle disappears. Then you know that you've hit your needle tip. So you're going to get underneath the skin, scan down, find your needle tip, and then you're going to go just distal to your needle tip and advance the needle a little bit. And then you see it again. And then you're going to go distal to it again. And then you're going to move the needle little by little as you walk it down towards the vessel. Here's an example of it on the mannequin. The doc is scanning down, saw that the needle tip disappear, then he advances the needle a little bit, then you see the needle tip disappear, and then you hit the vessel. Okay? Again, it requires continuous motion of both of your hands. The left hand is going to be moving with the probe, tracking the needle tip, as you advance with the right hand. So you're going to want to in my opinion, it really does take a lot more effort to be good at this. It takes coordination of both your left hand and your right hand. And for a novice learner, this is very difficult, and you can really box yourself in by really just doing sight marking, when in reality you want to be using ultrasound guidance. Here's how long axis is a much simpler technique. So here's how long axis is a much simpler technique, where you actually you stabilize your hand on the patient, you pincer grip your probe, you're going to want to access the skin really closer than that example in the picture is. You really want to kind of be close to your probe. And you're going to note that the probe has a seam. Think of the seam as the midline of the probe. And you're going to want to make sure that as you're accessing the skin, that the axis of your needle and the axis of the seam of the probe are one and the same. That's how you're going to be able to access the vessel and can maintain your needle in view the entire time. If you found that you're slightly off axis because you start losing your needle tip as you're going down, you want to go ahead and stop moving and do a slight rotation, right or left, until you see your needle tip again, and then continue to proceed. So you just want to be sure that you're lined up. That's really the most important and hardest step of using the ultrasound for a long axis technique. The rest of it, as you can see, is very easy. Once you have them both lined up, it's really easy to get down to the vessel. A lot of folks will complain to me that they're having difficulty with long axis because they really have a hard time switching from short to long. So what are some of the tricks that you want to use to make an effective switch from short to long axis? You really want to go ahead and find your vessel, center it in short axis. Then, as you've centered it, you want to slowly start to rotate to a long axis approach. As you're rotating, you may find that if you're not perfectly lined up with the vessel axis, the vessel is going to try to escape either left or right of the screen. If you find that the vessel is kind of moving towards the side of the screen, you just have to stop turning and recenter the vessel, and then continue turning again. If you do that, you always get to your long axis view, no question. So again, find the vessel in short axis, slowly start to rotate the probe, and if that vessel stays in the middle the whole time, then you already were in the middle of it, and you don't have to do anything, because you'll just get the long axis view. But if it starts to escape towards one side of the screen or the other, stop turning, slide the probe left or right until you've centered the vessel of choice again, always keeping the vessel of choice in view, and then continue to turn once it's centered. If you do it that way, you'll never accidentally scan one vessel in short and then switch to another vessel in long. Sometimes folks just put the probe down in long axis and try to identify the vessel. While you can do that if you go through the confirmation steps over again to confirm which one that you're really looking at the vein, that's fine. But that technique that I've just described is very useful for making sure that you're always looking at the same vessel, whether it be a central line or peripheral IV. Sometimes folks will tell me that the probe face is too big and that they have a hard time accessing the neck in long axis because the patient's neck's too short. Well, that might be the case, and you may have to use a short axis approach in certain patients. However, the lift technique is very useful, okay, very useful for this situation, where you can save a lot of real estate by just lifting the probe up and sneaking the needle underneath the probe, underneath the skin, and then putting the probe down again. Then you can really kind of save some real estate as you're trying to get to the vessel of choice. Here's some example of long axis approaches. Where you've got the needle tip in view the entire time. There you can see on the left side of the screen that was a little bit more challenging there to get into that vessel. Sometimes you have to do a little bit of a corkscrew motion to penetrate that vessel wall. Okay. The mistake would be to go ahead and continue to apply a lot of pressure and potentially hit the carotid, which is just distal to the vessel of choice in both those cases. The last and one of the most important steps is confirmation of the wire. You're going to want to confirm the wire in both short and long axis. Again, if you're not sure, just go ahead and ask for help. It's okay to pull the wire out and compress an artery. If you identify that you put a wire in an artery, while not ideal, then at the very least, the technique has worked. Don't feel like a failure in that case. Just go ahead and pull the wire out and put direct pressure and talk to your attending. Just do not dilate if you're not sure where you are. I put this video here to give you guys another example. I know I talked to the interns about this before, but if you're doing a femoral approach, go ahead and make sure that you're below the saphenous takeoff. That way, you know that you're not going to be, at any point in your procedure, above the inguinal canal and cause a retroperitoneal bleed if you make a mistake. So make sure that you're south or distal to the saphenous takeoff before attempting central line cannulation of the femoral vein. Some brief cases for review. Very easy to see that this is an artery that we're imaging with triphasic flow. Sometimes you're going to get coiling of the wire. If you scan the wire in two axes, you'll be able to identify that easily. And you can use different techniques to rescue that situation, but you probably just need to pass the wire again. Another view of the wire in the vessel. This is a view that illustrates that this patient really does not have a whole lot of free wall to work with. The carotid artery is just distal to the IJ in that case, and you really want to avoid accessing that site simply because you're not going to have a great space to work with. You probably want to look at the other side and be sure that you don't have a better vessel on that side. Perhaps rotating the patient's head, rotating the patient's neck a little bit will help you get a little bit of a better view. Regardless, not optimal. This patient unfortunately already has a thrombus in his vessel, probably from a previous attempt, and you don't want to access that site because you're going to have a hard time passing the wire. This is an example of why a short access technique where you're merely using site marking can be dangerous. This doctor is not aware of his needle tip location and is very likely going to hit the carotid artery, which is just distal to his plane of approach. Another example of a short access technique that, well, might have been successful is really causing a lot of trauma, and actually does not appear to have been successful because there's a lot of pressure being put on that vessel and there's no visualization of the needle tip. Just remember that using the ultrasound, you don't need to shake the needle. A lot of folks like to shake the needle or push the needle up and down to try and identify where the needle tip is. That's not required, okay? Really, if you have good technique, you shouldn't need to do those things, and you should be able to identify a needle tip pretty easily. And if you can't, then you just ask for help. Plenty of folks out there willing to help you. So pitfalls: attempting to access a small IJ, attempting to access a flat IJ, accessing where there's no free wall, loss of needle tip in the field of view. You must always have the needle tip in view, regardless of which technique you choose. If you don't have needle tip in field of view, then you really need to stop and ask for help. You don't want to access through a thrombus or a valve. Okay, if there's other anatomical structures or issues in your way, then make sure that you get a good scan through. And then continuing multiple attempts after you've really failed the procedure. Just ask for help if you're having that much difficulty. There's probably a reason why you're failing, and our goal is to teach you guys how to do this better and to really kind of help you with your technique. So I take immense pleasure in helping out in difficult central line situations. That's one of the things that I love doing is procedures with ultrasound. So just go ahead and ask for help, okay? And that's all I had for you. Good luck with your procedures, and hopefully you've gained a greater understanding of site marking versus ultrasound guided approach. Thank you.